So welcome everyone. I'm sure there might be a few other faces joining, but I am officially recording and going to kick us off. So hello and welcome to today's program hosted by Women in Medicine. My name is Megan Phillip and I serve as WIM's Innovation Officer. So it's wonderful to have you here with us. For anyone joining our programming, that's the first time. Women in Medicine is a national 501c3 nonprofit dedicated to educating, elevating, advancing women in healthcare. We are the national home for women in medicine, building the continuum from medical student to senior leaders through community education, leadership development, and advocacy. A couple of quick notes before we get started. This webinar is being recorded and will be available on WIM's website under Insights within the next week or so. So feel free to share with colleagues or rejoin us again. We also will welcome questions. Feel free to drop them through the chat throughout the program, or otherwise there might be a point where we can bring people into the conversation later on. Today's conversation couldn't be more timely in recognition of Mental Health Awareness Month. We're here to talk openly about the growing mental health crisis among women in medicine. Women physicians experience burnout rates at as high as 50 to 65%, consistently higher than their male peers, alongside greater levels of emotional exhaustion, mental fatigue, and challenges within work life integration. These aren't just personal struggles, they reflect sustained systemic issues that we're all trying to address. This session is designed to create a space for open conversation and learning, and our hope is that as you leave here today, you have a clearer picture for some of the challenges, but also some of the opportunities we have together to support one another. We have some incredible thought leaders joining us today, and I'll introduce our incredible WIMbassadors as part of our speakers viewer shortly. But first, I want to give a warm handoff to our Chief Wellness Officer, Dr. Tiger, who's going to just bring us along as we celebrate and support each other during Mental Health Awareness Month.
Oh, thank you, Megan. Thank you, Doctors Mahoney and Dr. Roberts, for being here with us today. We are focused on Mental Health Awareness Month, and today also is the stress pillar focus for Lifestyle Medicine Week. So today couldn't be more perfect. Your topics that you're going to be sharing with us are just so needed now more than ever. And it can be really hard whether you are live with us or whether you are tuning in on the replay to just kind of flip that switch from whatever you were doing. So I thought I would just help us transition into our session together, just bring ourselves back into our bodies and out of busy thinking minds. So inviting you to first notice how you're sitting. Are you comfortable? Can you get more comfortable? Are your feet touching something solid? Is your back supported? If not, just take a moment to make sure that your feet and your back are supported. Make sure you're sitting in a way that feels comfortable, that you're not hunched over, but your heart is lifted and you are open to learning and connecting with us today. If you want to kick your socks and shoes off, you can do that and give your feet some barefoot time. And your eyes can either be soft or closed, whatever feels good for you. Taking a moment to feel your feet touching the ground. Feel your body touching the chair or the sofa or whatever you're sitting on. Notice the parts of your body that are being supported. Feel your clothing touching your body. Even feel the temperature of the air on your skin that's not covered. And then taking a moment to press your feet down into whatever's supporting it and feel your legs contract. And then release that and let go. Lift your shoulders up towards your ears. Feel the contraction in your shoulder muscles. And then feel that release as you lower them and let go. Pressing your feet back into the ground, feel your legs contract. Sense that. And then sense the release. Lifting your shoulders up towards your ears, feel the lift, feel the contraction, and then release. Take a breath in through your nose. Fill your body with breath. Open your mouth, exhale, and release. Breathe back in through your nose. Feel your body expand and lift with breath. Open your mouth, exhale, and release. Let's put that all together now. Press into your feet. Lift your shoulders. Breathe in. Feel all the muscles working here. Open your mouth and release everything. Settling a little bit more into your seat. Pressing in through the floor. Let your shoulders lift. Feel all the muscles contract. Breathe in and release. Settling in a bit more. Last one. Press down, lift up, contract and sense. Breathe breath into your body. Open your mouth, exhale and soften. Letting your body really feel held by that support beneath you, and then let your eyes gently open and gaze forward. Turning it over back to Megan, Dr. Mahoney, and Dr. Roberts.
Thank you. That was wonderful. I hope everyone feels nourished and relaxed and ready to have this conversation and then charge into our long weekend. But in the interim, I'm going to turn it over to Dr. Mahoney to share some of her sentiments.
Thank you. And thank you, Robin. That was amazing. I feel already better. So I was asked to share a little bit about why burnout persists despite attention and investment. And my reflections come as someone who's actually worked in this space since 2002, before burnout and wellness were a thing. And they had no attention and no investment. And now they have quite a bit. And so the thought is, why haven't things changed? And I thought, and I'm going to share a little bit about that. Do you mind moving on to the next slide? So my thoughts are, so much of the conversation is it's a systemic issue, and I 100% agree. The systems are broken, and there are personal contributions that we each make as people who work in medicine who also add to the challenge. And so I will say the system 100% needs to change. And there are things that we can do to make it better for us until it does. And so until both of those things happen, I think system changes aren't making a difference and personal changes aren't making a difference. I also think it's incredibly important to add to that, that the way that we show up for medicine and the things that exacerbate burnout and make it harder for us to move through medicine, which is already hard, in a sustainable way, are not our fault. They were trained into us. And I think it's incredibly important to recognize how we were trained to think and how we were trained to move through medicine, which is a cultural problem, and choosing how we want to move forward. We can recognize that we are victims, and in many ways we are, as women, and societal expectations and the expectations of the culture of medicine. Or we can choose to say we can opt out of that victimhood space and lean into the agency and control about how we show up. One of the reasons that I think this is absolutely so important is that I believe that the effective solutions that we haven't found yet are really going to come from the physicians themselves. And that when we are healthy, we can advocate well. We have the capacity and the capability to do that. And when we are exhausted, depleted, below empty, and in a cortisol bath and in sympathomimetic storm, it's very hard to do that. We've left the solutions to others, and that hasn't made effective change. So why are these current wellness and organizational strategies failing? And I really do believe that we're trying to solve burnout within the same systems and structures that created it. And in fact, even this language burnout is not the most helpful word. And one of the things I think we could do is move beyond burnout and really thinking about it not as a problem, but as what kind of culture do we want to have? And it has become somewhat of a diagnosis. Now, there are bits of that that are helpful because healthcare works within a system of a diagnosis and a problem, but that means that we bring the same approaches to solutions. And so far, the medical approach to this diagnosis, which is not really a healthcare diagnosis, have not created solutions. So why I would say we haven't changed and solved it is that so far we haven't shifted the culture and expectations in medicine. And how I really like to think about this is the way that we were trained to approach things and the way that we're trained in training and the way that we still, for the most part, train trainees is for a different kind of medicine than we practice now. Medicine has changed. Those approaches of self-sacrifice and martyrdom and over responsibility and over functioning, they worked a lot better in a system where we had our own panel of patients and no intermediaries. And medicine wasn't a business per se, it was really more of a relationship. And that is not where we are now. And so the culture needs to shift for the kind of medicine that we have. We've also very much tried to fix burnout from inside the system, and I think that has led to it being a diagnosis and very medicalized solutions. And notice the surveys and checklists and scoring, and that hasn't really led to solutions. To me, it's an incredibly complex, complicated problem that requires creative, innovative, outside the box thinking. And so far, we haven't gone there, and our systems haven't gone there. We are more and more going there, and I think this group, WIMS, is going there, and a lot of the innovative solutions that are coming from individuals and outside the system are really where I think the answers will ultimately lie. It's going to be a collaboration. And then our systems are not appreciating the cost of unwellness. And I will say that's the difference between when I started in this work and where we are now, that we are at least putting money towards it. And we are better advocating for the cost of physicians who are, and I'll use the word burnout, but our quality of care is not as good. The cost is higher. The retention situation is actually causing more pain for the people who are staying. And we're not looking at those costs. And so until we begin to make those evident as individuals and then our systems, and those of you who are listening who have leadership roles, I really encourage you to don't let the cost of the unwellness go unnoticed. And I think the last real piece that we haven't brought into this is that we tend to, in medicine, try to solve problems at the thought level. And a lot of the burnout solutions come at the physiologic level and the somatic level. And we haven't really addressed the trauma. We haven't really brought in mindfulness. We sort of say it's, yoga and mindfulness, and you can do that at lunch, but really brought that into how did we get here and where are we going? And so I think that that's really one of the biggest missing pieces that is going to need to shift going forward. So as I see it, it's a culture problem, and that physician wellness should really be more of a value than a problem. We've labeled it as a problem by giving it this name of burnout, and really can we think about it as a value of our organizations, a value of medicine, something that we all value, and create a culture where things are sustainable, doable, pleasurable. We have a culture of collective suffering. So you can probably skip ahead one more. So if we don't change how we move forward as individuals, and ultimately that will change the culture, nothing will change. And so I just want to reflect on a lot of the things that I'm referring to here. If we continue to normalize things like self-sacrifice and martyrdom and judgment and call those excellence and commitment, which is what they were labeled when I first started my career, we continue to normalize making decisions from guilt or avoiding blame and shame and having, peer reviews and M&Ms from this place of shame, blame, and guilt. We will not change the culture of medicine, and we won't get out of burnout. And if we continue to practice, I call them the overs and the toxics because it's a little bit lighthearted, but things like over responsibility and over functioning and personalizing and overcompensating, we tell ourselves that these are good medicine, but we also judge our trainees and we judge our colleagues that way. And so can we step out of those things? And can we begin to trust ourselves and stop accommodating excessively, which would also be people pleasing, and stop suggesting that we can do it all ourselves, which is toxic independence. And we do it at a cost. That's why these are toxic. All of these things are fine. A little bit of doubt, some independence, some endurance is good, but they become toxic when we do too much of them. And then we end up bitter, resentful, exhausted, and depleted. So if the corollary is also true. If the system doesn't change, nothing will change. And so normalizing needing support at a systemic level, and for institutions offering support that actually works. And I've started to do a lot more work with institutions because I think they need to understand that what support does actually work. And burnout checklists to me are not the answer. And so really thinking about sort of top-notch, psychologically safe wellness programming that, in my experience, when it's provided outside the institution, is safer for folks. It doesn't mean that you don't want to have some programming within the institution to show that you believe in it, but to recognize honestly that both are needed and collaboration is needed. And then to allow the flexibility and choice without judgment. We sort of say one way is better than the other. And I think that that's not necessarily true. And for each of us, support and mental health preventive care looks different. And can we let go of our patterns of judgment? And then training leaders is really where the wellness efforts need to go. If leaders aren't leading with a lens to wellness, and the primary part of this is modeling wellness, it really is not supported. And many people say to me, well, how do I teach this to my trainees? Or how do I teach this to, everyone? And my thought is, if the leaders are not thinking about it in the same way, we're really setting ourselves up for our failure. So just remembering that the burnout is trained and acculturated, and we've given it these fancy definitions of, emotional exhaustion, cynicism, and feeling ineffectual. And I would say that that's ubiquitous in medicine. So it looks like everyone in medicine, if we want to say, what does it look like in women? It looks like women, though, who are successful on the surface, but they're struggling underneath. And I think we all can compensate to some degree until we can't. And it looks like people really grasping onto control and navigating the world through what is pretty much a toxic culture. And just recognizing that in women, it's also exacerbated. And this is why women's rates are higher. We're the emotional leaders of our family. And society expects literally more of us as caretakers in the medical realm, but also in our families. Many of us are eldest daughters, and pretty much the expectations in our family are unreasonable. Our own expectations are unreasonable of ourselves and of our colleagues. So one actionable shift, just to think about how can you move forward differently? What can you do? And I would say mindfulness for me is the actionable shift. And I think about it much more than meditating on a mat, really thinking about it physiologically and attending to your own nervous system. We can't advocate well when we are reacting and in a cortisol bath. And also really thinking about some of these philosophic tenets of mindfulness or approaches and attitudes, ways of moving through the world. If we don't move through intentionally and we're reacting, we are not actually headed anywhere specifically. So that gets me to being aware of how we're showing up and having an intention of how we want to show up. And the intention that I invite you all to lean into is what would love do? This is a question that I ask actually for everything, and it sounds a bit woo. I did a TED Talk about it recently, but I believe that even if, hospital administrators could ask this when they are thinking about what to fund and what not to fund, we can think about this as to whether to see the late patient or not. We can think about it in terms of whether to work full-time or part-time. And the piece about this we forgot is that it's really what would love do for you as a human, what would love do for the other people involved, and that can go to your patients, your family, and then what would love do for the greater world. And it's an and, not an or. And so I encourage you, as you're thinking about this complex problem of burnout, this is a very simple question that can give you some different lighthearted insight and an out-of-the-box approach.
Thank you, Dr. Mahoney. That was wonderful. I'm really excited to dive in with you in just a bit, but I'm going to turn it over to Dr. Roberts to share a little bit, and then we'll all kind of have a group discussion.
Thank you for that introduction. Thank you, Dr. Mahoney, for starting us off, and as well for Dr. Tiger. I loved the meditation, feeling better already. So I just want to first off by saying thank you to Women in Medicine for the invitation today. This is such a much needed conversation, but unfortunately one that doesn't happen often enough. I am Dr. Renee Roberts. I'm a board certified family medicine physician, Castle Connolly top doctor, and recent TEDx speaker as well. Still waiting for my talk to drop, but thank you so much for today. I think it's safe to say we've all been there. We've all been forced to follow the unwritten rules of high achievers and being a physician in today's era. And what does that look like? The one that gets rewarded for pushing through, for seeing that patient that walks in late when you know you have other responsibilities to take care of outside of the hospital wards or outside of the exam room. We know that our work is not done. I always say seeing patients is the easy part, but the real work starts when you walk out of that exam room. The notes, the prior auths, or maybe 2 or 3, the prescription that didn't go through, the family member that shows up unexpectedly and wants a full rundown of what just happened in the exam room, the phone calls, the lab reviews, and feeling that weight day in and day out. And then we're asked to do that not just once per day, not just 3 times per day, but we're multiplying that by 10, 15, 20, 25 patients per day. And the sad thing is that we have created a culture where we better not say a word about what we're experiencing. Because oftentimes, practicing medicine, we struggle in silence. You can go ahead and advance the slide. So there is a hidden pandemic. I don't think this is just an issue that's isolated here in the United States, but this is obviously popping up in other areas across the world. But the focus obviously today will be for here in the United States. Many of you are probably familiar with the stats that 46% of women physicians report feeling burnout versus our male counterparts, which is a little bit less. I also like to think about the second shift saga. What happens after the workday is over? Most of us are going to job number 2 or job number 3 for that matter, if we have parents, where we're actually putting in an extra 8.5 hours of work each week, most of the time obviously going uncompensated. And something interesting that I found in certain communities, particularly communities of color, when physicians are no longer present, when we leave, when we retire or say, that's it, life expectancy drops for many of us. This stat in particular, about 31 days of extra life expectancy, is actually the impact that happens when African American physicians are no longer in the community. A lot of our patients are losing 31 days. That's an entire month. I don't know what some of you would do with an extra month of life expectancy. So the impact of burnout, the moral injury, extends far beyond the exam room in ourselves, but it actually permeates our communities, the very people we have set out to heal. So I think many of us know that burnout is not just a disease. I think it's the symptom, obviously, of a bigger systemic problem. And one thing I want to ask you guys about or to think about is if I asked you if I had a 10-pound weight, I'm going to ask our audience members is how much do you think this weighs? If anyone is even brave enough, it's a 10-pound weight. Most people are going to say, oh, well, duh, Dr. Roberts, it weighs 10 pounds. But here's the reframe I want you to think about. I think how much this weighs actually depends on how long you're carrying the weight. If I hand it to you and say, hold on to it for maybe 3 seconds, okay, that may not be too bad. But then what if I hand it to Dr. Mahoney and ask her to carry it for 3 minutes? Or if I pass it on to Dr. Tiger and ask her to hold on to this for 3 hours, I guarantee it's going to feel a lot different depending on how long you carry the weight. This is burnout. The longer you carry it, the longer you carry that burden, the heavier it feels. And think about what that does, not only for yourself, but for your colleagues. Even now, seeing that younger with residents, fellows, medical students. You can go ahead and fast forward the slide. One thing that I have come to realize is that our system is set up where we are, unfortunately, rewarding unsustainability. We're calling it dedication, but in the grand scheme of things, a lot of what's happening is unsustainable. I'm pretty sure you've been in the staff meeting where the person who hits their metric is praised nonstop, and that might leaving you feeling some type of way. Well, I didn't meet this metric, or my notes are still unsigned, guilty as of right now. Or I have yet to go and make another phone call to that patient or that parent. But we really need to stop and think about what exactly are we celebrating? So we don't just reward dedication, we are rewarding unsustainability. And for some of us, for me personally, up until about 4 years ago, I was actually quite ashamed to tell people about my path to medicine. Some of us have started dealing with burnout long before we ever donned our white coats and walked into the exam room or the hospital ward as an attending. My background actually involved getting rejected from medical school, not once, not 5 times, not 10 times. I wish it was just that simple, but actually 50 medical school rejections. I thought that was the end of my issue, only to get to medical school and realize I am not a fan of standardized tests and failed my boards not once, but twice. And that was something I was extremely ashamed to admit to and didn't admit it to anybody and carried that burden with me, which was a mistake. Because then what happened is as I went through medical school and residency, I was exhausted before I had even gotten started. And when I mentor pre-medical students, I see so much of that now, thinking, how can this be happening to them at such a young age? But it's the system we've created. It's the system that they're walking into. You can go ahead and advance the next slide. So one thing I had to realize is that I need to find a way to survive. Yes, the system, as unfortunately as it is stands right now, hasn't changed, even though I know we're all working on that. But I had to come to terms with what can I do? How can I sustain myself? And I didn't realize that what I was actually doing was creating my own system, one that I like to share with my colleagues and one that I definitely share with students that I mentor. And one thing to keep in mind is coping keeps you afloat, but I think resilience actually teaches you how to swim, because in order to survive where we are at right now with practicing, resilience is key. And I'm actually here to tell you that I think resilience is more than just a personality trait. It's a methodology. So I've actually created one that I want to share with you all today, and I've got something for you. But one of the things that's helped me is thinking about locating your lesson. It's called the limits method, not limits, but limits. It's actually an acronym. We don't have time to go through all of it today. But I think one thing that was helpful when I get in those times of stress or my back is against the wall is, what is this particular situation teaching me? What lesson can I extract from that difficult patient encounter? Or the nurse that's having a bad day and needing to provide guidance and leadership towards her. What lessons can I extract from that? The next step is yielding your assets. Something good has to come out of this. Dealing with the stress and the burnout is not a liability per se. It's not a weakness, but where can we actually find assets, things that we bring to the table that can help us through these difficult situations? So I clearly won't have time to go into all of that today. However, if you are interested, at completely no charge, you can scan the QR code. I've got a quick start guide to share you a little bit more about the resiliency method that I use with myself, with my colleagues, and with pre-med students as well. And I just want to leave you with this before we send it back to Megan, that I just want to commend everyone. One, for showing up today, one, for having the courage to speak up and to be present. And please give yourself grace. Please give yourself grace and know that it's not an issue with you, but we're obviously fighting a bigger system. But we need each and every one of you, and we need each and every one of your voices to help move the needle forward and make a difference.
Thank you so much. I'm doing too many things on my production end, but I'm ready to gear shift and welcome Dr. Mahoney back and Dr. Roberts. First of all, thank you both so much for sharing such thoughtful remarks. And I have so many quotes and nuggets already I'm taking away, but I really want to just kind of dig in further with each of you and talk through a little bit more in depth with each of you on some of this. A lot of what we heard from both of you is kind of this push pull between the system level and the individual level and the sort of dance that we play within that. So I want to kind of just start with some where does the responsibility and accountability come in these parts, and where should responsibility sit between physicians and organizations in addressing burnout? Renee, I'll give you a breath and I'll start with Dr. Mahoney and we can turn over to you as well.
My thought is the responsibility and accountability is both and, because so much of what actually Dr. Roberts and I both reflected on was what we glorify and what we decide is an excellent, good physician. And as long as we and our colleagues continue to bring that as the expectation and to judge people about their decisions, and we have such a judgment culture in medicine, nothing's going to change. The institutions are not off the hook. I also have, as I mentioned, this really firm belief that we do have a responsibility to advocate well. And we were taught, honestly, in my day and age, to not advocate. And that was not in our lane, and we shouldn't speak up, and that actually patients were our responsibility and we should leave all these other solutions to someone else. And that has not led us to a good place. And so to me, it's how can we advocate effectively? What tools do we need as physicians, as women, as leaders? And I think really leaning into strategic advocacy and recognizing what is in our control and where we can bring the conversations. We do have a lot more power than we think. And as the retention problem becomes a bigger and bigger problem, we have more power, as it turns out. And so I think to recognize that we don't need to stay in our lane as patient care providers or in that, in the exam room. And when we step out of the exam room, that's where we can make a lot of impact. And then obviously systems do need to be willing to be flexible and change. And I have hope, because it seems like, for better or worse, they're beginning to listen. They've begun to see the crisis. And so I do think we have this unique window in time, if we choose not to be victims of it and instead choose to lean into advocating for ourselves and our colleagues, our patients, and I loved Dr. Roberts' add-on of our communities, because really that's where these organizations are there to serve. So to recognize where we're in alignment and advocate from that place and from this sort of heart-centered healing place, which is where we're all coming from. I do, we're often at war, and we use a lot of war terminology in medicine, even with our administrators. And my thought is that people in healthcare administration could do a lot of other things and probably make a lot more money, and it'd probably be a lot easier. So there is something in alignment there. And so how can we figure out where the alignment is and begin to work together? If we don't work together, we won't get there.
Dr. Roberts,
Yeah, sure. Yeah, I think it's twofold. I think both us as physicians have some responsibility, but at the same time, the systems within which we operate also have equal, I'll actually go a step further and say probably a little bit more responsibility. One thing, as Dr. Mahoney has mentioned, one thing that I think would work well for us is to speak up more. Staying silent does not work. It only serves to defeat us. And I think it's also teaching the generations, our future healers that are coming after us, that this is okay behavior. And clearly it's not. That being said, the organizations, corporations, for those of us that are, not self-employed, they have responsibility as well. We can only go so far. I don't think the responsibility should solely be placed on physicians. It's like trying to light a fire with a box of soggy matches. Like, we all know you are going to go nowhere very quickly with that. I think that we also need to be very strategic about how we go about that. I don't think any of us need any more pizza parties or, maybe happy hours or whatever after work, but we need to start speaking up and saying, hey, this is not working. This particular schedule is not working. Seeing patients past a certain time of day or before the lunch break, this, that, and the other, whatever those little micro shifts may be. Those are the things that people need to hear, because let's be honest, a lot of the folks that are making the decisions also have never gone to medical school, have never sat for their boards, have never dealt with the prior authorizations in real time or the frustrated families. But we do, and we bring obviously a lot of value to the table. We need to speak up and let that be heard.
I really appreciate that. And I think, as a non-physician myself, and I also think we also have to recognize both of you are speaking about the perspective of caring for, but I always remind everybody, every single human is a patient. So as we think about each of you also receiving and experiencing these things, I wonder, it's just, as we, whether it's seeing it in others that we are working alongside or with, or within ourselves, where are these behaviors and parts showing up, and how can we sort of identify those markers for burnout, and whether they're intentional or unintentional? So Dr. Roberts, I'll start with you to say, what are those sort of behaviors that you see or experience within yourself or within others, and try to help. I always say we're always in the sort of sick care model, but how we get into the preventative care model, especially as it comes to burnout.
One of the things that is imperative, which I kind of hinted on in the previous question, is being very strategic with our yeses and being strategic with our nos in terms of setting healthy boundaries. And that's one of the things that, again, we're not taught. You say yes to everything. Don't turn down that patient that walked in late. Yes, we're going to stay up late. Yes, we're going to do yes, 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 yes. But then where does that leave us other than exhausted, stretched razor thin? I've had to learn how to do that. I'll be honest. I've been practicing now 15 years, but when I started out, certainly, out of residency training, there was no such thing as no. because I didn't want to be labeled as the doctor that, isn't a team player and isn't taking on, extra work and this, that, and the other. And it cost me. It cost me exhaustion, stress, bringing that stress home, which is obviously not fair, to your loved ones. And I think we need to get very strategic with our no's in terms of saying, you know what, no, this is not okay. No, we're not going to be taking on any extra patients. No, we're not going to be coming in on, weekends or whatever the case may be. It's obviously different for each organization, and that can feel very scary because a lot of us are not in places where we have psychological safety. And I think that's needed so that we're not being reprimanded or not being thought of as being doctorly enough because we're speaking up for ourselves and trying to set healthy boundaries.
Dr. Mahoney, I wonder, as you work kind of coaching at the system level, having been within the system, how does this play out, and how are you helping, or how is it to be receiving these prescription models that you may be providing, and are they being receptive, or is there opportunity for people to manage up right now to bring forth this identification of these signs?
Well, and if I think about the identification, part of me says that it's, and Dr. Roberts mentioned this, it's hidden. We hide it really well. And so most people don't know who's burnt out and not. And in fact, I used to, and I was a chief of a department, think it's like, oh, it's the ones whose charts are behind, or, oh, it's the ones who are disruptive. Sometimes the ones who have everything looking beautiful on paper are the ones who really are struggling the most. And so I'm not sure we can pick up on the signs. I think we actually just need to assume that it's everywhere. And I loved your thought about preventive care. And I think that that's probably, could we just build a culture of preventive care? I worked at Kaiser or TPMG, and it was originally started as a all-encompassing health system where we did preventive care because if we prevented things, we wouldn't have to pay for them in the end. It's shifted over time. But so that's really, and I'm a pediatrician. In pediatrics, we work on preventive care. But I'm thinking here, if we think about when we start our careers, how can we take care of ourselves as well? I have found, we used to say in wellness, put on your oxygen mask on first. And there are a lot of physicians who won't do that, can't do that, or it's not accepted where they are. But I don't think anyone can argue with putting it on also. And so my thought is sometimes that as well can soften it. I will be fully honest here that I have real trouble with boundaries when I use that word. Even when you said it, I get anxious. It's just funny. And I'm not sure why, but that's just and saying no makes me anxious. So I have come up with creative ways to do that without calling it those things. And for me, I think that's helpful. And I think if leaders can model this and we can model it ourselves, that the culture will ultimately change. So I like to say, I wish I could, but I can't. I wish it were possible. I would love to, but it's not possible. Because oftentimes we would love to. We'd love to see the late patient if time were not an issue, and if we didn't have other patients to see, and if we didn't have families at home and other things. And so to me, it actually is the equivalent of no, but I don't have to say no. I also love the idea of boundaries from a place of love. That's the question, love for me, love for my child who's going to be left at school without anyone to pick them up, love for the patient that, if I stay here, I'll be burnt out and I'll leave eventually, all of these things, and love for the system that we have to have a sustainable model. So my thought for this sort of preventive care is that if we show up with intention, which is, it's a yoga term, and I'm a yoga and mindfulness teacher, but I think it's what we need in medicine, which is how we want to experience the role. What do we want to bring to it? Then it becomes very easy to just, if your intention is to show up as a caring human, you have to care for yourself, you're caring for other people, you want to care for the long term. Then all of a sudden these decisions aren't really even decisions, because it's very clear that if you're here to care for yourself, your family, your patients, your communities, there's a clear answer about which patient to see or not see and whether you're going to take on this project. It's a totally different way than we were trained, but for me, it's been very helpful in sort of having the noise quiet down and for me, not losing as much energy and I'm just going to say emotional currency of saying no or having boundaries. I even find it works great with my mother too. And so sometimes these things like work in different spaces and just recognizing tools that you have and creative ways of approaching it can hopefully lead to a shift. And I have not found that organizations, they don't get upset when you say, I wish I could, I would love to, but I can't. Like, and then it's like that you say, well, you can't. And I'm like, well, if you took off all these other responsibilities, I could. Like, it opens up a very different conversation that isn't, I failed. It's just, or I love, it's not possible. I wish I could, but it's not possible.
I really appreciate that. As someone that also gets a little itchy around using no or boundaries, I appreciate that I'm not alone. I wonder with that advice, I really appreciate the reframe. And I wonder for both of you, as we think about the spectrum of women in medicine's community of, medical students all the way up to very experienced professionals like yourself, I feel sometimes as we get older, it's almost easier to, even though we are all expressing here that we're experiencing that friction, I think I wonder for our younger audiences, how do we empower them to recognize, Dr. Roberts, when you were saying when you were in medical school, the eagerness feels so necessary to feel like your career is moving forward. So what advice would you give for our young up and comers or people that are kind of mid-career that are trying to balance like, that promotion when people are dealing with those types of tensions? What sort of do these still work and how to pick and choose when you have to make those sacrifices or not, and how to make those decisions? And I don't know that there's a one size fits all, but I'm just curious to see if we can maybe offer some thoughts and wisdom there.
Yeah, I think that's an excellent question. The reframe, the mental mindset shift is key. And that's one thing that I did not have that I wish I had when I was in medical school. I'm a completely different person now than I was then. Thank God, most of us are. But with regards to like the up and coming, generation of our healthcare heroes, medical students, medicine is tough. Doctoring is tough, but that's okay. It's okay for us to do the hard things. The setbacks, failures, feeling inadequate, all of those things kind of come with the package, but it's not final and it's not a personality flaw. I think one of the game changers for me was realizing that it's okay to be behind your peers. It's okay not to have all the answers. It's okay to not have this outward appearance or facade that everything is great and everything is perfect, because deep down inside, you know that you're going to have those days where it's not. But it's okay to speak up. And it's okay to be your authentic self, not wear the veil, not hide in the corners because you bombed your OBGYN, clerkship exam or whatever the case may be. And every time I lead with that, it gives other people permission to do the same.
I appreciate that. I did put in the chat that I would welcome any questions. So if you want to raise your hand or come off mute, or if you want to drop it in the chat, if you're unable, I'm happy to relay a question from the audience.
While we're waiting, I just have a thought too about the trainees that comes up a lot. I coach in some training programs, and what I think is really hard for trainees is that they are in this spot where other people are evaluating them and they are dependent on other people approving. And so there is a part of this that we actually don't have the agency, or they don't as a trainee, to potentially speak up to the degree that they might want to. And I also see them potentially advocating for themselves in ways that are not effective when they do. So to me, the real change has to come at the attending level and what we expect and how we model it and what we share. And Dr. Roberts was talking about being honest and vulnerable and being open with our own failures and our own vulnerabilities and our own challenges, that when we create a safe space, that's where they can have a safe space. And maybe to honor that, like, we wish it were different. We wish healthcare weren't like this. And one of the framings that I bring to the sort of trainees is really saying, like, when you're done, you need to be aware that, like, what you're expected to do here isn't necessarily sustainable for your life. In an ideal world, we'll fix training eventually, but I do think it kind of has to be this trickle down, because what I have seen is if we tell them that this is all unreasonable and you need to stand up for yourself, it's a little bit like you can harm yourself in that path if you're not careful. And so to me, it's a little bit like a dance. And I again drop back into this idea of intention. You know, if your intention is to be a healer and someone who cares, just include yourself in the package. Then you won't be the person who's advocating. There's a lot of and actually the attendings complain about the trainees, right? That they don't want to work hard enough and they don't know what it takes and they don't understand. And there's kind of a both are true. And so to me, the idea is being really clear about why you're here and what you're doing, and that training is a little bit different than the end game. I think the problem is that we don't change it. Like, we hit the end and then we keep acting like that. And the expectation is that we'll continue to do that. And as you mentioned, that's not sustainable, right? That's just a setup for failure, honestly, which is why we are where we are. So I think if as attendings we can speak to it and let them know, you know, that while they are here, in the end, these are not helpful behaviors that will last for a lifetime. And while you're open to it, maybe not every attending is open to it. I find that can be a helpful way. And then sharing whatever tools you have and whatever ideas you have. I'm seeing Dr. Tiger up there, right? Teach them to breathe, teach them stress reduction, help them focus on what is in their control. But I worry a little bit about the trainees, because yes, they are burnt out, but we can't control all the environments that they're in. And so until we get the system changed, I don't want to make it harder than it already is.
I didn't see anybody pop up, and so we are getting closer to time. So I'm just gonna help close us out. So again, thank you both, and Dr. Tiger, and we'll thank everybody again at the end. But it is Mental Health Awareness Month, so thank you for bringing awareness to this. I think we've covered a lot of ground. What is one change or commitment that you are currently, whether it's personal or with your team, trying to do to protect your well-being and sustainability at work? And just want to get your quick tips from each of you.
That's a good question. Oh my goodness. Well, I think where I'm at in my career right now, it's still circling back to healthy boundaries. Just making the conscious decision that I'm going to leave as much of my work at work as I can and reclaim my personal time, after hours, weekends, for me and my family, so that I can sustain myself. Because if I can't sustain myself, then I won't be able to show up for my patients.
I have the luck of going second, so I had a little more time to think as you were talking. And I think for me, I have really been leaning into sort of a strengths-based approach of what I do, what I love, and what I'm good at, and trying to grow that rather than always focusing on what I need to fix. And that has brought a lot more joy. And that's coupled with the idea that it's okay to actually have fun and enjoy things. I think that we're so caught up in the idea of medicine being hard and being a physician is hard. And so for me, that gets my nervous system and my physiology in a place where I can also then have more creative solutions to some of the challenging problems. But the root of it is really looking at, what do I love? I often think back to, there's a physician, Dr. Rachel Naomi Remen, who is somewhat famous. She created the healer's art in medical schools, and she's almost 90 now. She lives near me. And her first year of the healer's art was my first year at UCSF a long, long time ago. But she has these 3 questions, which she calls anti-burnout questions. I would say they're anti-mental health challenge questions as well. And she asks these questions: what surprised you, what inspired you, and what touched your heart? So not like 3 things you're grateful for. It's what inspired you, what surprised you, and what touched your heart. And to me, those get at the things that light you up, that make the job worth doing, and help you reconnect to sort of your why, which can then give you more capacity and more energy to have, I'm going to use your healthy boundaries in whatever way you do them, right? Because it's so hard when we're depleted. So those questions to me are really magical questions that I actually ask a lot, particularly the what touched your heart. I'm a pediatrician, so it seems like a fun way to just sort of see like what lights you up or what makes you come alive, one thing in your day. And that can really, to me, work as sort of an immunity badge for some of the other challenges that we face.
Well, thank you so much. And on that note, what touched my heart was you both sharing today. It was such a pleasure to work with you both and meet you. I just want to share a couple of resources and thank everybody for joining us, and a reminder that we are recording this. And so if you think somebody could benefit, you can always reshare it later. We have several upcoming events, including our summit and other conferences that Women in Medicine is supporting. So I encourage you to check those out. I also want to point out the deadline to nominations for I Stand With Her Awards, which happens during the summit and our gala, is June 12th. So if you know some wonderful physicians that are doing amazing work, we would love to highlight them, and please nominate your friends and colleagues, and maybe some lovely people on this call, maybe. And if you want to be a person that is a speaker, is part of our elevated community, please consider joining as a WIMbassador to be on our speakers bureau. Or if you are not ready for that, maybe you can join as a regular WIMbassador. We're trying to create more connectivity across our community. So you can visit our website. All of these resources are there. I want to thank Dr. Roberts, Dr. Mahoney, and Dr. Tiger for sharing their time with us today, especially as we all lead into a holiday weekend. I just want to wish everybody a safe and happy holiday as we celebrate Memorial Day. And that's it for today. So I am going to stop everything on my side once I can get there.